Hi, I'm Frank Spear. I want to welcome you to this segment. What we're going to talk about in this segment is something that I get lots of questions about from practitioners. And that is, at what age is it okay to put an implant in place? In other words, how young? And the other question that comes up is, if we don't put an implant in place in a young person, what happens to that ridge over the period of time from when we first start thinking about it till 5, 6, 7 years later, when we actually may place the implant? So the kind of patient we're talking about is one like this. And a lot of this material that I'm going to be sharing with you, in fact, is material that Vince Kokich, the orthodontist in particular, put a lot of time and effort into developing. And then Dave Matthews and Vince and I actually published part of this material, and I'll share that publication with you and the dates of it. But a lot of these are Vince's cases, as he's really intimately involved as the orthodontist in talking with the restorative dentist about the timing issues. So this is a patient of Vince's who is just about 13 years of age, missing a left lateral incisor, and he did orthodontics, and now a little bit over 2 years later, at 15 years and 3 months, the ridge is in place. Is it okay to put an implant in? Or is it too soon? And the simple way to understand this is to realize that we don't want to place an implant in a patient who is still growing vertically. As the face grows, the adjacent teeth erupt to maintain occlusion, but the implants aren't capable of eruption, which means as the adjacent teeth erupt, the implant appears to submerge. And to give you a very graphic example of it, this is a case from one of our faculty club members, Will Baker, and Will posted this year on our faculty club website to ask for ideas. But what you see is a right central incisor implant. It was placed when she was a freshman in high school, so 13, 14 years of age, and now she's 23, 24 years of age. And what you're looking at is the outcome of what happens when the patient's face grows, the teeth erupt, but the implant doesn't. And now you end up with a fixture significantly too far apical, and oftentimes also malpositioned facial lingually because of the nature of the facial growth and eruption. So here's a close-up version on it. So you can imagine this is a very difficult situation to now correct. You have to think about taking the implant out, trying to graft bone vertically, graft soft tissue, put in a new implant. You might think about using distraction osteotomies, where you actually do a single tooth osteotomy around the implant and then pull it down and lingually. You might think about putting the implant to sleep. Those would be all the kinds of things that you have to think about. The reality is, ideally, the implant shouldn't have been placed. And so that brings the question up, when is it okay to actually place the implant? Well, to answer that, you need to think about facial growth. We know that what an orthodontist does is they take cephalometric films. And the cephalometric films allow them to see the relationship of the maxilla to the mandible, and they can do a set of serial cephalometric films to see, is there a change taking place. So in other words, in this patient who's 15 years and 3 months old, if Vince was to now take a cephalometric film, he could then do another one a year later, and by looking at where the mandible is in the posterior, ramus length, and also nasion and menton in the anterior, if what he sees when he overlays the new cephalometric film and the old cephalometric film is a change, then he knows facial growth is still occurring. And I know Vince has a much more detailed knowledge of this than I do, but from the studies that the University of Washington has done, he would tell you the average female is completing growth somewhere between the age of 17 and 18. The average male doesn't complete growth until somewhere around the age of 21. The trouble is those are average numbers, so they don't help you know when to place the implant. In other words, knowing that an average female's done growing at 17 or 18, what if your female isn't done growing at 18 and you place the implant? So what Vince would recommend is that around in a female between the age of 17 and 18, you take a cephalometric film, and then 1 year later you take a second cephalometric film. If in fact those two films, when laid on each other, are identical, he would tell you it's probably safe to place the implant, assuming you waited till the patient was over 17 to start. In a young male, you wouldn't take the first cephalometric film until somewhere between 20 and 21, and then you'd take the second cephalometric film a year later. Now, what happens if there's a difference? Then it tells you the patient's still growing. And what do? You wait another year, take another film. When you finally get two films a year apart that perfectly overlay on top of each other, then it's probably safe to place the fixture. Now, what that brings up is what do you do for the patients in the meantime, and what happens to the ridges in these patients in the meantime? So your orthodontist has the ability of measuring ramus height and anterior facial height and overlaying the cephs, as I said, but the question becomes a clinical management question. So typically following orthodontics, space maintenance is going to be done with a retainer. And so in this 15-year-old 3-month patient, the space maintenance was a retainer with a tooth on it, with a plastic tooth on it. Obviously, the patient doesn't want that for 5 years if it's a young boy, or 6 years. And so through the years, I have tried a number of different designs for how to fabricate some sort of pontic. By far, to me, a bonded pontic is the most effective tool, where we actually bond it to the adjacent teeth. But you have to realize that if it's going to be there 2, 3, 4, 5, 6 years, there's a possibility that that patient's going to loosen it or knock it out, especially an active young boy playing sports. So you have to think about designing it in a way that it's easily rebonded, or if you want, also removed, because when it comes time to place the implant, you want to easily remove it. So I've done things using fiber, such as Ribond, and you can make a very nice pontic using fiber. The trouble is you can't remove it easily, because when you go to remove it, you destroy the fiber and you can't put it back in. So by far and away, what I have found to be the most effective long-term solution is a pontic bonded to orthodontic wire. And this one happens to be made by Vince Kokich Jr. Here's that patient 1 year post-treatment. Here is a really ideal pontic for long-term use. So the patient wore her retainer for a year with the tooth on the retainer. And then 1 year later, Vince Jr. made this with 030 orthodontic wire that then bends into the pontic site, and the laboratory processes the tooth to it. Now, why is this so nice? Because you can take it on and off, and if they knock it loose, it's easy to put back in. It's not like cutting through fiber. It's not like bonding it to the interproximals of the adjacent teeth. The only place this is attached is on the lingual of the cingulums where that wire is bent. And you also make that little curlicue in the wire so that when they bite on it, that's what keeps the tooth from pivoting. If you just do a straight wire, when they bite on it, it has a tendency to get mobile and pivot. And so we don't want any movement of this pontic. And so the wire's bent with those little curlicues at the end, which is what gives it stability when the patient's incising on it. And here's what it looks like bonded in the mouth. The composite is only over the curlicue ends of the wire. It's not bonding the tooth itself to the adjacent teeth. So it's a very simple pontic to take in and out. They look fine. The trick is that you have to have room to do this occlusally. But if the patient's just finished orthodontics, there's almost always room because they rarely have a deep overbite. And so in this case, you simply keep that wire way up near the cingulum, and now you've got a fixed restoration, which when the time comes is easily removable by the surgeon, so they can put their implant in, and then you can put the Pontic right back over the top of it. What I wouldn't do most of the time is worry about things like ovate Pontics and all of that. The surgeon's going to take care of that at the time of implant placement. So typically this is just a partial ridge lap, if you will, modified ridge lap. It maintains the space, holds the teeth in position, and makes the patient not suffer through having a removable appliance. Now, the one thing I will tell you is when you treat a patient who has had the space opened orthodontically, the challenge, of course, for the orthodontist is when the cuspid moves in next to the central, the easy thing for the orthodontist is to just tip the crowns apart, which leaves the roots doing this. What the orthodontist needs to do is to bodily separate the teeth so the roots are parallel, leaving room for the implant. You want to be sure that you have a curlicue in your band of your wire that bonds very stably, because I have seen instances where, in fact, without a solid bonded retainer, the roots have drifted back together and it's required orthodontics again to separate them. So there's reasons other than just for patient preference that we want to use a rigidly bonded retainer, especially in a case where there was an orthodontic opening of the space. Now, what happens to the ridge during these 4 or 5 years, or 6, or whatever it is? This patient's 15. If it was a boy, they might have to go 5 or 6 years before they could have the implant placed. And so the real question is, do edentulous ridges resorb? And again, Vince has put a tremendous amount of effort into this portion of this presentation. And again, he and Dave and I published on it years ago, so I'll share with you what was done. But he actually did a lot of the manpower of doing this actual research project. So we know that there are patients who do get ridge resorption. Okay? Here is a patient 6 months post-orthodontics. Okay? Here is another patient 6 months post-orthodontics. And they have totally different results. Jamie is the patient who has no resorption 6 months post-treatment, and Jennifer actually has significant resorption 6 months post-treatment. And Vince and Dave and I treated both of these young women with implants. And I'm going to share with you why they have such different responses. If you looked at Jennifer at the completion of orthodontics 6 months earlier, you would have seen that she looked like this. She had a lateral incisor. Jennifer was playing soccer, and the lateral incisor was avulsed and not found for some reason. And so Jennifer lost her tooth and was left with an extraction site, basically. And 6 months later, she looks like that. And so in that instance, yes, we know, in fact, that ridges do resorb. And there's been a lot of research that has looked at what happens to ridges following tooth loss in the anterior. Now, in this day and age, what would typically be done if you were extracting an anterior tooth is you would be doing some sort of socket preservation. You'd be putting in some graft material, perhaps membrane of some kind. But that's not Jennifer's situation. She lost the tooth traumatically on a sports field. There wasn't any socket preservation done at the time. Now, why do you see so much resorption when a tooth is lost? Well, what you want to do is look at how much of, quote, the ridge was the root of the tooth, and how much of the ridge is actually the cortical plate, the socket wall. Look at how thin the socket wall is, and realize that the bulk of the width of the ridge was the root of the tooth. Other than that, you have a lot of marrow spaces. So you don't have a lot of dense cortical bone around the root of the tooth. When the tooth comes out, there's not a lot of dense material there. Now, if you go back to 1967, Carlson actually looked at taking teeth out and doing nothing and following them for 5 years. And so he used models, he used tomograms to measure what happened to the width of the ridges in the maxillary anterior on 36 patients. So working with radiographs and measurements, he measured the change in the ridge at 6 months, 1 year, 2, 3, 4, and 5 years. What he found was that in the first 6 months, the ridge thickness diminishes by 23%, mostly from the facial. So if you looked at Jennifer's pictures of her ridge 6 months post-tooth loss, Jennifer fits almost perfectly what Carlson said would happen. Is you lose the root, which is the bulk of what's holding the ridge, you've got the cortical plate, it starts to resorb, and you get 23% loss. If you then, and here's a picture of Jennifer at 6 months to show you what that looks like, notice the palate has had some loss, but not nearly as much as the facial. Now, what Carlson then did is follow these patients, as I said, over 5 years, and in fact, they lose another 11% over the 5 years. So in Jennifer's case, if she lost this lateral at age 15, and we waited 5 years to do the implant when she was 20, which is possible. Some young women don't complete growth until then. If you waited 5 years for her, she would have lost a total of 34% of her ridge, and now the surgeon would have to come back and recreate that ridge. So there are young people who, because of age, can't have an implant. And in fact, because the implant can't be placed at that age, they're going to need significant augmentation later on. Who are those young people? They're people who have lost a tooth. Now, what about Jamie? Because Jamie's 6 months post-treatment. Her ridge doesn't look like it's resorbed at all, because Jamie's ridge was created orthodontically. This is Jamie pre-treatment. What do you notice? She's congenitally missing the right lateral incisor, and the cuspid and central have erupted next to each other. Now, what Vince is going to do is he's going to create space for the lateral incisor by moving the central and cuspid apart. So he is going to create the ridge orthodontically. Now, what you need to know is, as you create the ridge orthodontically, you don't lay down medullary bone, you lay down socket wall as teeth move apart. And you have a cuspid and a central, which are actually much bigger roots than the lateral incisor, and the ridge you create is determined by the size of the roots moving apart. You don't create a lateral incisor with ridge when you're moving apart a central and a cuspid. You create a much bigger ridge than that. So here she is at the completion of orthodontic treatment. The centrals have now been lined up with her facial midline, the cuspid's in the correct position, the ridge has been created. This is a very different ridge than losing a tooth and essentially having nothing but a lot of medullary bone and a little socket wall. If you look at the radiograph of this case, look at how, as those two teeth moved apart, look at the density of bone in that radiograph, laying down cortical bone. Now, I'm not going to show you a histology of this patient, but here is one of Vince's slides showing histologically what happens as a tooth is moved. This root is moving to the right, and what's it laying down? It's laying down socket wall, a much denser bone, much denser ridge. So the question that Vince and Dave and I had, because we have traditionally in our careers gotten referred lots of patients with congenitally missing anterior teeth. And when you get a patient with congenitally missing anterior teeth, oftentimes the teeth have moved together, and the orthodontist opens the space, and then you wonder what happens to that ridge over time. So the question is, what does happen to this ridge? Where does it go, okay, for 4 or 5 years if you have to wait that long? So what we did, and in reality, Vince was the primary person that did most of this, but here was the publication. It was Seminars in Orthodontics in 1997, myself, Dave Matthews, and Vince Kokage, and it was an entire series of articles about the interdisciplinary management of single-tooth implants. This was the study that we looked at about what happens to these ridges. Now, in reality, what we did is we used patients that had had Maryland bridges, because we had a lot of those from the 80s. So, back before single-tooth implants were a popular thing, if you had a young person congenitally missing a tooth, typically in the anterior, they'd get the teeth lined up and you'd do a Maryland bridge. So we had 20 patients, okay, who had had orthodontic treatment to open up spaces, the lateral incisor being the most common one, and then were treated with Maryland bridges. And the average time post-treatment was 4.5 years. And so good 4 to 5 year reference for what we would do if we were having to wait to place an implant for somebody. We ended up with 29 actual pontic sites that were opened up orthodontically. And so what Vince did is he had post-ortho models, and then we had the average 4.5 year model. Section those models so you could literally measure the stone cast, measure the soft tissue thickness buccolingually, mid-ridge, at the end of orthodontic treatment and 4.5 years later on average. So if you mark those section cast with the alignment of that central or cuspid, and you then measured a certain distance up, you measure the ridge, and you now have that measurement. But the other thing he did is he got tomograms of those ridges, so he could look at what changes occurred radiographically in the buccolingual dimension of the ridge. And honestly, I think when we did all of this in the mid-90s, none of us was really quite sure what the results would be. I certainly would have expected that a ridge is going to resorb. If you don't put something in it, a ridge is going to resorb. And what we found was that, in fact, there was less than 1% resorption over the 4.5 years. And so when we had patients who had had orthodontically opened ridges, there was absolutely no reason to rush into the implant treatment, provided that you maintain tooth position with the bonded retainer. Because if you didn't maintain tooth position with the bonded retainer, the risk was the roots drifting back together and then not having room for the implant later on. So if we now go back and we take a look at our end of treatment here, where Vince opened up the space and moved the central over and the cuspid over, and we compare it with 4 years later, the ridges basically look exactly the same. There's been no change in that 4 years of treatment time at all. So the message is really quite clear. If you have a young person who loses an anterior tooth and they're too young for an implant, they're going to end up with augmentation later. I don't know that I would put a lot of energy into augmenting the site now at the young age, because the truth is, if you augment it with bone and do all those other things, you can certainly put things like bio-os in there to minimize the resorption. But the reality is, if you have to wait 5 or 6 years or 7 years or 10 years following tooth loss in a young person, there's going to be a need to augment that site when the implant's done. On the other hand, if you're dealing with a patient who's already congenitally missing the tooth or lost the tooth and the teeth came together and the orthodontist has now opened the space, the reality is you're going to lose almost nothing waiting your 4, 5, 6 years, whatever it is. So here is the surgical guide that was done for this patient. There, in this case, Dave Matthews laid a flap to gain access to the ridge. He's leaving 1.5 millimeters of buccal bone, so he's basically putting his implant slightly to the palatal aspect of the ridge. Because the ridge was opened up orthodontically, he actually has to take a couple millimeters of bone away so that we can get our 3 to 4 millimeter distance between our final gingival margin position and the head of the fixture, so I have room for my abutment and then to gradualize my emergence profile. Here is what it looked like the day of implant placement. Today, you could also certainly consider doing this without laying a flap, doing it with a punch. You would have to measure from the incisal edge to know where your depth should be. And because this is such a solid ridge, today you could also consider, if you did punch it, you could consider actually placing a temporary on it the same day, assuming that the implant took at least 35 newtons of torque to get it down into the bone. In this case, we covered it up, we let it sit 3 to 4 months. She wore her retainer that she'd been wearing for over 4 years. We just shortened it so it didn't interfere with the soft tissue, and then did a punch uncovery right to the head of the fixture. This is a 4 millimeter healing abutment, and so you can see, in fact, the head of the fixture is exactly 4 millimeters below the gingival margin level that we're basically trying to maintain. Here was the temporary place the day of uncovery, so that the punch was done, the temporary put into place. I let this patient go another couple months before I then did my final impression, and you then on the right have the final restoration. So a patient who was treated by orthodontic space opening and went well over 4 years before the implant was placed, no problems whatsoever, because no, we don't get the resorption. So I hope this has helped clear up for some of you some thoughts about timing of placement. If we kind of go through and conclude, the critical factors are, we want to know that the patient's done growing at the time of implant placement. That means for a female, we won't take our first cephalometric film until at least after age 17. For a boy, we won't take our first cephalometric film until at least the age of 20. Then we wait 1 full year, take a second film. If you overlay the films and there's a difference, then go another year, take another film. When you finally get 2 films that are identical, after the age of 17 for women, after the age of 20 for males, then you can probably safely put your implant in. Now, if you have a young person that loses a tooth and they can't have the implant placed, sure, do some kind of socket preservation procedure. Don't go crazy about it, because if you have to wait 5 or 6 or 7 years before you can place the implant, you're going to probably have to graft anyway. But if the ridge was created orthodontically, the good news is you're going to have a great ridge 5 years later to put the implant in. You're not going to have to deal with probably a lot of augmentation. So it's been my pleasure to share all this with you, and I look forward to seeing you in another segment.